Good afternoon and welcome to the BMC Pediatrics NEST360 Supplement launch. We are talking about the small and sick newborn care, learnings for implementation across Africa and beyond. I hope you're feeling as excited as I'm feeling because I'm ready to go. And I'm your host, Dr. Sandeni Chiume from Malawi. Welcome to this afternoon's BMC launch, pediatric launch. I'm your host, Dr. Msandeni Chiume from Malawi, and hope you enjoy the launch. The launch is live online right now. You have open access to it, and that's the QR code there, and you are happy to download it, share it, use it, and enjoy it in your everyday work. And this is all done, has all been done in support of the faster progress to national targets, implementing the WHO UNICEF 10 core components for the small and sick newborn. A huge thank you to this marvelous team that I work together with, a team of 150 authors, 70% of which are African, 54% female. Wow, thank you so much, guys. We really appreciate your work, and let's push on. A huge thank you to our editing, overseeing reviews, managing editorial teams. Oh, the lovely peer reviewers, thank you so much for your time. The BMC team and the NEST360 Alliance funders, thank you, thank you, thank you. Without further ado, let me take you through the agenda. I'll do the scene setting with my colleague Rebecca. We'll look at the small and sick newborn care agency and the implementation gaps. And Rebecca will talk to you about the NEST360 Alliance. Then we'll have a team of lovely speakers that will do the supplement overview, the speedy details on the papers, and also you have a chance to think through the action faster together. And please do not hesitate to post questions on the chat and there will be a question and answer session throughout the session. Thank you. Now, the scene. Why are we focusing on the small and sick newborn? Really, most of us know that the global burden is very huge for newborn care. And the newborn conditions are the leading cause of death in the low income countries and ranked top in the global burden of disease. There is a huge sense of urgency when you look at the SDGs. The newborn neonate mortality reduction is even slower in the last decade. We need to push on. But right now is a time when there's high level political commitment and some learnings from other countries who are moving faster. We need to leverage on this to actually move forward. There are some equity gaps that have been established. Africa has 13% of the world's population, but over 45% of the neonatal deaths, which is very, very high. Many of these, 63 of the African countries, are off track for the SDG 3.2 in Africa. We really need to push. Evidence is there that we need to reach a neonatal mortality rate of about 12 per 1,000 newborn births. But really, for us to achieve this, we need high-impact interventions like CPAP and KMC, but we need them done at a high coverage and of good quality. But there's also evidence that we're sharing that there's good return on investment. Yes, the cost of setup is pretty high for these newborns, but once you do set up, you get good returns. For every $1 in Tanzania, we got the investment case shows that there's 8 to 12 dollar returns. So that's really a really good return on investment. We have tried and still trying to move things from policy to action so that they don't just remain in the books, but we actually be able to see them with our hands. There is a policy right now that every district, or about 80% of the districts, should have functioning newborn care unit with CPAP. But also the WHO guidelines are there for the standards of care for the small and sick newborn, and the preterm guidelines, including the IKMC. The NEST360 group has indeed worked to carry this evidence across and use it with the WHO 10 components, focusing really on the 7 of these components, moving things forward. Together, we have a really ambitious target for the small and sick newborn. The NAP coverage target 4 requires us to reach 80% of the districts to have 2 inpatient units for small and sick newborn, including CPAP. Indeed, to have high coverage and high quality interventions for us to get a high impact. This is us up on the move, but the system change can be really hard to do. It can be much slower than we want it to do. The progress report from the 2023, the recent gathering, where we reviewed the NAP and EpiPen and worked with several countries together, shows that there's actually a huge implementation gap for the small and sick newborn 10 core components, especially looking at issues of space, staff, supplies, and money. Well, with the focus of these health system building blocks, looking at leadership, finance, infrastructure, medical supplies, human resource information, KMC included, we have co-designed with governments, with learnings from the NEST360, and now here we are talking about the papers in supplement. And these papers you'll have a good detail and flavor of as we move along in this launch. Please, at this point, welcome my colleague Rebecca, who will take us through the next slides.
Hi, everyone. I'm Rebecca Richards-Gordon. I'm a bioengineer and part of the NEST team, and it's my pleasure to share with you who is NEST and what are we doing. NEST stands for Newborn Essential Solutions and Technologies. Our team is an alliance of 22 different organizations. 17 of these organizations are based in Africa, but we are all working together to support governments in African countries that are working to meet SDG 3.2 for newborn survival. NEST is helping to fill gaps in care for small and sick newborns and in health technology management. We are working to deliver a health systems package that includes a bundle of technologies to deliver life-saving care to help meet ENAP coverage target 4. We are working to monitor improvement in coverage and use this information to drive further improvements in care. Right now, our team is working in 4 countries, in Malawi, in Kenya, in Tanzania, and Nigeria. And NEST has been implemented at 67 hospitals in partnership with governments. These hospitals together deliver more than 500,000 babies every year, and they admit nearly 100,000 babies every year.
Thanks so much, Rebecca. And welcome to everyone. My name is Sarah Merlis Collins, and I'm a South African trained clinician specializing in pediatrics. And today I have the privilege of providing an overview of the NEST360 supplement on behalf of the NEST Alliance. So why this supplement? Its purpose is to share implementation learning from NEST360 for faster systems change that's needed for small and sick newborn care, referred to from now as SSNC in Africa and beyond. Since 2019, the NEST Alliance has been working to implement and scale quality care for small and sick newborns, moving beyond a one-at-a-time approach to a health systems approach, including innovative device installation, training, improved information systems, and quality improvement with mentorship. Next. As we've heard, there is a major gap for implementation and investment, and we need these for impact. There were no published multi-country analyses of this magnitude, assessing and informing level 2 newborn care scale-up in alignment with ENAP targets. Next. So we set about delivering this supplement with papers aiming to inform action in these areas so that we can achieve more impact together. Next. The initial batch of supplement papers includes 10 that correspond to the components on the left-hand side of the slide, which link to the WHO UNICEF 10 core components. Please use the QR code to access and download the papers via the BMC website. The papers report practical lessons for implementation in LMICs, including the co-development of standardized data tools, systematic approaches to device selection, costing and setup of a level 2 newborn unit, interdisciplinary education modules, assessment of neonatal infection detection, and approaches to help catalyze investment. Again, our goal was to share learning to inform practical actions to implement WHO, UNICEF, and other global guidelines. The 7 papers out now provide just some of our learning, particularly on the setup phase of NEST360 for systems change. 3 more are coming soon, and additional ones are planned for the future, so keep your eyes out. Next. Before getting into the papers, I want to reflect on the large, diverse, multidisciplinary team that got us here and made this supplement possible. Impressively, the team across the papers consisted of over 150 authors, like Sandy mentioned, 70% from Africa, over 50% female. We've also supported many authors publishing for the first time, which has been really great. We ensured best practice for more equitable inclusion whilst remaining compliant to ICMJE recommended criteria for authorship. And on this, 2 recent important publications that informed our processes are pictured here, and links to these papers will be posted in the chat. Next. So how do these papers fit together to tell a story? Faster progress to meet global neonatal mortality targets requires 80% of districts to have functioning SSNC units, providing WHO level 2 newborn care by 2025. No small task. To achieve this, we need the right infrastructure, devices, data, skilled staff, which all clearly necessitate system change and moving beyond that one at a time approach that I mentioned. NEST started implementing during COVID, and we were forced to learn about resilient health systems quickly. COVID exposed weaknesses in health systems, especially impacting vulnerable users like newborns. Our first paper in the supplement explores lessons from COVID to protect progress for newborn survival as we move forward together. To provide level 2 newborn care, devices are necessary. But we all know that these aren't always accessible, affordable, or appropriate for low resource settings. So we set out to develop target product profiles, or TPPs, for key newborn devices, summarizing desired optimal and minimal characteristics per device. And a team led by Biomeds then devised a device qualification process to test devices on the market against the TPPs, as well as the usability on the front line, meaning we now have systematic evidence for what devices work best where, which is really useful to inform device choice for these settings. Devices are necessary, but let's be honest, not sufficient, because alone they can't sustain quality care. They need to be used by an interdisciplinary team. And our NEST education team developed materials and methods for interdisciplinary education, fostering collaboration by breaking down professional silos. And the inclusion of biomedical engineers in these processes was especially novel. We need data to understand gaps and drive action. The health facility assessment tool is purposed to assess readiness of a hospital for level 2 unit. And the neonatal inpatient dataset consists of 60 core variables needed to track quality and impact of small and sick newborn care. Both of these tools are being used across the countries and data generated being used for action. Data collected through these tools actually facilitated a study that assessed the infection detection gaps in neonatal units, guiding subsequent hospital level quality improvement processes. And we all know the truth that very little is possible without money. The development of a device and furniture costing tool aims to inform planners how much it will actually cost to set up a level 2 unit. The detailed approach to setting up an investment case for SSNC scale-up, including assessing return on investment, was carried out in Tanzania, which galvanized government to commit more investment for level 2 newborn care in the country. The approach can be replicated in other settings. Next. To take a deeper dive into the papers across the thematic areas, I'll be joined by esteemed colleagues and co-authors on various papers, Millicent, Edith, and Alice, a biomedical engineer, neonatal nurse, and health economist. And we'll be focusing on sharing what we learned from practical large-scale systems change for SSNC and what next. Over to you, Millicent.
Thank you so much, Sarah, for such a wonderful introduction. And so let's talk about devices. What was new for us, what we learned, and what next. So for us to offer quality sick and newborn care, we definitely need devices. And the devices that we need are not just devices, but the devices that are fit for purpose, especially considering the low income settings or low resource settings. And so NEST360 in these particular papers, 2 papers that are talking about target product profile and device qualification, realized that we needed to come up with particular characteristics, the minimum characteristics required for these particular low resource settings, and profile them so that we be able to know what type of characteristics are required per device. And so this was a Delphi-like process that was used to define the performance characteristics for newborn devices. And that is what we are referring to as TPP. And so the approach involved, reviewing WHO, guidelines, having different experts to do this, to develop this, having stakeholders meeting, and many other activities in order to come up with this minimum performance characteristics. And so we came up with 15 TPPs that were for newborn devices. And apart from that, we developed an evidence-based process to qualify 23 priority neonatal devices, which were fit for low resource settings. And now, what did we learn from there? From the 23 neonatal devices, we tested 271 models or makes, but only 45, which is 17%, met the corresponding TPP metrics that we had set. A few of those devices were eliminated because of the technical, others were environmental, and others were after the usability testing. So what is next after all this? We need to adapt and apply the TPP development process to other fields beyond newborn care. This is the only way that we'll be able to realize what exactly do we need, what is fit for our environment, and what do we require in our newborn care. And when it comes to the device qualification process, what process do we follow? So these 2 papers are very definite, and they give us clear guideline on what to do when we are doing the device qualification process, and even how to develop the TPP. The next thing that we are supposed to do is to engage with the local and the national, with the local and the global, team to be able to, we need to engage with the national and the global agency to ensure that appropriate devices are on the national procurement list. I know we have priority devices list in each and every country. We also have guidelines from WHO on the priority devices list required for newborn care. And so we need to engage really widely with both national and the global agency to ensure that all the priority devices that we require are all in the national procurement list. And one of the major barriers for us getting the devices are cost and lack of distribution. And so how do we manage this? We need to ensure that we share the market so that we are able to reduce the newborn care cost, and we're also able to distribute evenly. With those few remarks, allow me to invite my colleague Edith to talk about education ecosystem. Thank you.
Thank you so much, Millicent. Hello, everybody. My name is Edith Gesheha, and I'll be speaking on behalf of the education team to describe our paper, which describes how we developed an education ecosystem, which is quite vibrant as we speak. So One of the 10 components that has been mentioned is human resource. It is necessary for us to have high quality, high performing team who will be able to deliver the newborn care that we require. So as a team, traditionally, we know that this team consists of doctors and nurses. And what we did that was new is that to this team, with our governments in all our countries, we included our biomedical professionals as part of this team to ensure that we are not only able to deliver the service, but also include the use of technology, the use of devices to be able to make our work easier. Working with all our stakeholders, these are associations, regulatory bodies, our pre-service lecturers. We worked and together we came up with materials which could be used across countries and which each country could then take and adapt and use for their settings. All the materials that we developed were based on needs which were identified by all the stakeholders. And when we developed these materials, we applied adult learning principles and also included very robust quality assurance in the process. So you can go to our website and you can be able to access this. These are generic and they can be used in any setting. And we have lots of modules, job aids, videos. We have scenarios both for the clinical team and the biomedical team. The other thing that we did is the fact that we are good health professionals doesn't mean that we are able to teach. And so what we did was we were able to ensure that all the trainers who are involved in training these adapted materials were trained in a generic instructor course. And what we learned from all this is that all our professional teams, when we work together, when we train together, when we develop materials together, then we are able to have better.
I'll pick up from Edith there. Hopefully she'll be able to rejoin us. But now moving on to implementing evidence-based care. We know the world does not need more tools, but small and sick newborn care is still new. We only had the first WHO guidelines for quality SSNC in facilities in 2020, not so long ago. Initially, when existing tools for system readiness and neonatal inpatient data tools were mapped, we found there were major gaps for key ingredients and components for small and sick newborns. So we set out with governments to co-create tools to address these gaps. These tools are based on WHO guidelines and can be used widely and adapted. The Health Facility Assessment Tool is now being used across 4 countries, with the paper on tool development and initial results coming soon. The tool can be completed in 1 day to assess readiness for SSNC. The neonatal inpatient dataset is parsimonious, meaning it is restrained to only 60 variables which are critical for assessing impact and which were agreed by numerous experts and teams across multiple countries. We've learned a lot about the tools and how they can be improved through their use across the 4 countries. Both are being refined with the aim to move to an open source software for easier adaptation, and we're aiming for linkage with existing systems like the DHIS2. And these tools are available for download via the implementation toolkit, which has been shared in the chat. Both tools were applied to a clinical question. What is the status of infection detection in newborn units with NEST? We were able to link health facility data and individual clinical data to answer this question. We learned that while neonatal blood culture is low across most facilities, some facilities outperform. We created a framework to categorize facilities based on detection performance to inform targeted quality improvement strategies, so that it's not just a one-size-fits-all. Going forward, we can learn from outperforming facilities, strengthen collaboration between neonatal units and laboratories, and leverage the NEST network for innovative diagnostic testing and combating antimicrobial resistance. Next. Does anybody remember 2022? That was when we started implementing, and country teams were truly amazing with everyone living on Zoom through COVID. Implementing through something as unexpected as COVID meant that numerous lessons were learned to inform going forward. Through collection of new qualitative data and rigorous analysis led by teams of qualitative scientists in each country, mitigation strategies to system shocks like COVID were organized into 2 tracks. COVID-specific, like improvements of IPC practices, which we saw across many settings, and health system protection pivots, such as improved information systems and surveillance. Going forward, we can leverage practices introduced during COVID to protect small and sick newborn care progress. And we can also seize funding opportunities that arise during epidemic shocks to drive the newborn agenda. Over to you, Alice.
Thank you, Sarah. I'm Alice Tarus, very happy to be speaking from Tanzania, where hundreds of delegates have convened for the 2nd RAMCA Congress. Listening to the commitment to newborn survival is truly inspiring. Once again, acknowledging the rise of the small and sick newborn health on the global agenda, and with only 7 years to the SDG timeline, countries need to be enabled to go faster on implementation and resource mobilization. This is because the wide health system planning and costing tools have a gap for small and sick newborn components, leading to undercosting of newborn health. The need for devices, furniture, skilled personnel, the right infrastructure among other health system components to support high quality care cannot be overemphasized. But the key question is which ones, how many, and how much will it cost? This inspired the development of a newborn-specific planning and costing tool that covers the type, quantity, and cost of devices, furniture, and user training at device installation. The planning and the costing tool can easily be customizable based on the context and used by non-economic experts to generate the procurement report, allowing acquisition of context-appropriate devices and cost estimate reports within a very short time frame. This tool, along with other adapted tools, were used in Tanzania to systematically analyze cost and life-saved data to scale to 80% of district hospitals, that's around 146, and all regional referral hospitals. And this evidence-based investment case aimed to support government in making a case and catalyzing resources for small and sick newborn, which has seen the government of Tanzania invest millions of dollars in the scale-up of small and sick newborn countrywide. What we learned is the costs are not small, but the return on investment is high. Infrastructure is the main cost driver, but once annualized over its useful life, the cost is actually less than that of human resource. Also noting the cost of devices are minimal. Also noted, to increase the resource envelope, there is need for leadership and commitment. Moving forward, we aim to include other components, including consumables, spare parts, and move to a more user-friendly platform for wider use. Please visit the implementation toolkit to download and interact with the tool, and also find the details of the analysis in Tanzania from the 2 papers. Thank you, and over to you, Nicole.
My name is David Kadara, and in this paper, we sought to understand mitigation strategies employed during COVID-19 to protect small and sick newborn care and inform solutions for resilience. We conducted multi-country qualitative research with small and sick newborn care health system actors in 4 African countries, Kenya, Nigeria, Malawi, and Tanzania. We identified mitigation strategies organized by two pathways. Pathway 1, COVID-19 infection responses with secondary benefit to small and sick newborn care, and Pathway 2, health system mitigation strategies and adaptations during the pandemic with secondary benefit to small and sick newborn care. The implications for investment and improvements include investment from governments across the health system to protect gains made and address gaps, which include developing an investment case for small and sick newborn care, support for family-centered care approaches, investing in information systems, community linkages to support post-discharge care, and investments in human resources for health for both numbers and scalings.
Hello, I'm Dr. James Cross, a research fellow at LSHTM. Today, it's my pleasure to introduce our new publication titled Neonatal Inpatient Dataset for Small and Sick Newborn Care in Low and Middle Income Countries, Systematic Development and Multi-Country Operationalization with NEST360. Our publication details the collaborative creation and implementation of a core inpatient dataset in alignment with the goals of the Every Newborn Action Plan. The development process started with a review of existing neonatal ward data tools and datasets from high mortality settings. This review laid the foundation for our co-design phase, involving over 40 government policymakers, implementers, and clinicians. Through multi-stakeholder workshops, we streamlined an initial list of 300 variables down to a core set of 60. The dataset now has been successfully implemented in 69 units in 4 African countries and holds over 450,000 individual records. Ownership of the dataset rests with country governments and facilities, enhancing its utility through linkage with live QI dashboard and national level DHS2 servers. The dataset has now also become a global public good. This allows for its download, adoption, and usage today, enabling facilities or countries to measure the impact, coverage, and quality of level 2 care, expediting progress in reducing the annual 2.3 million neonatal deaths.
My name is Sarah Merlis-Collins, and we focused a paper on neonatal infection. Infections kill babies. We need to get better at detecting infections if we hope to reduce infection-related neonatal deaths. We designed a cross-sectional study which aimed to quantify the neonatal infection detection gap in 61 hospitals linked to NEST. Over 140,000 neonatal admission records were analysed. We found that while antibiotic use across hospitals was 70.4%, blood culture use was only 6.3%, emphasising an urgent need for improved detection and antibiotic stewardship. If we stratify this graph by country, we still see a major gap for each, but larger in Malawi, where most hospitals with NEST are district level, compared to majority secondary and tertiary level hospitals in remaining countries. Despite the marked underutilization of blood culture at the country level, we found stark hospital level variation, with some hospitals outperforming. The takeaway message is that we can learn from these outperforming hospitals, and it emphasizes the opportunity for cross-hospital and cross-country learning through partnerships.
Hi, my name is Becca Kirby, and for our target product profile paper, our focus was on the many life-saving newborn technologies that exist in high-income countries, but are not currently available in low and middle-income countries. One potential way of closing this gap in effective, affordable, and easy-to-use newborn technologies is by specifically designing new products for these settings. Target product profiles, or TPPs, are used to define unmet needs and help product manufacturers understand the key features of an innovation, including the desired characteristics. We used a Delphi-like process to develop 15 newborn TPPs, which UNICEF published in April 2020 and has since been viewed over 7,000 times. This approach was novel in scope, breadth, and reach, establishing a unique methodology to apply the TPP process to medical technologies for newborn care demonstrates the potential to replicate this approach for other global health burdens.
Lake Manguilo, NEST360 Malawi Study Coordinator at Kamuzu University of Health Sciences. Most medical devices often fail in low-resource hospital settings because they cannot withstand the humidity, dust, frequent user turnover, complex maintenance, and erratic power sources. We have developed an 8-step process to identify medical devices that are reliable, affordable, light, and easy to use in order to enhance quality newborn care. Of 271 devices considered, only 23 products passed the evaluations. 2,457 devices were installed across 65 newborn wards in Tanzania, Malawi, Kenya, Nigeria, and a 99% uptime has been observed by continuous monitoring with minimal device failures. Our hope is that similar processes can be adapted and expanded beyond the care of newborns to benefit other low-resource settings. Join us in making a difference. Thank you.
Hi, my name is Josephine Langton, and in our education paper, we describe the feasibility and short-term outcomes of the approach used for development of national neonatal training with inclusion of medical devices. This unique approach included involvement of stakeholders throughout, inclusion of biomedical engineers and technicians within the healthcare team, emphasis on interprofessional education, development of adaptable educational materials, qualification of trainers through a generic instructors course, GIC, and use of a robust quality assurance process. Educational modules, scenarios, job aids, and videos have been published, with 2,962 downloads by June 2022. The inclusion of the biomedical team as a valued member of the healthcare team was novel and immensely successful in increasing awareness and respect for these cadres on both sides, but also in improving cross-cadre knowledge of maintenance and importance of medical devices in newborn care units. The GIC and its small group interdisciplinary approach have positively influenced neonatal care, biomed and medical relationships, and device maintenance, whilst the overall approach has ensured that high-quality interprofessional training is included within national agendas for neonatal care.
My name is Alice Sarus. On behalf of our interdisciplinary team of 16 authors from all over the world, we are excited to share a rapid overview of our paper. To save millions of newborn lives each year requires high-quality neonatal care with functional devices, fixtures, and trained healthcare professionals. However, there are gaps for these inputs and lack of publicly available tools to inform planning and costing. Together, our team systematically developed an open access tool to inform the number of devices and furniture needed and the cost for small and sick newborn neonatal level 2 care. We reviewed existing tools, then co-designed a new tool and refine it through national use in Tanzania. The tool incorporates furniture and device lists based on WHO guidelines, UNICEF manuals, and national policies. Unit costs were derived from government procurement agencies in Kenya, Nigeria, and Tanzania. The tool has 3 components: furniture and fixtures with 18 default but editable items, neonatal devices with 16 product categories, user training. The tool was practical to use, informing Tanzania procurement list and cost estimate for level 2 scale up in 171 hospitals. Please use this tool and help us improve. Thank you.
Hello, I'm Rose Kamoyo, and for our investment case paper, our aim was to develop a 5-step framework to be used in a low and middle-income country and provide data-driven analysis to make a case for additional investment in small and sick newborn care. We did this analysis for Tanzania, and in our framework, first we reviewed the country policies and guidelines. Then we estimated the potential benefits of scaling up small and sick newborn care using the LifeSave tool. Third, we estimated the cost of scaling up newborn care, after which we then calculated the return on investment and finally identified potential financing opportunities. From our results, the returns are quite significant, with a potential return of between 8 and 12 for every dollar invested, and our proposed 5-step framework will be used by other countries wanting to accelerate progress.
Hi, my name is Rebecca Penzias, and I'm pleased to share a quick overview of this paper on behalf of our team. Many newborn deaths are preventable, and to save lives, hospitals must be ready to provide high-quality care. To meet global newborn targets, we need to know what health system ingredients hospitals have available, which is often assessed through health facility assessments, or HFAs. Some HFA tools measure wider service provision and obstetric care. However, there's a content gap where HFA tools did not comprehensively assess readiness for level 2 small and sick newborn care. To address this gap, NEST360 and UNICEF jointly led development of a new HFA tool. This tool was systematically co-designed with 4 country governments and reviewed by more than 150 multidisciplinary experts with a focus on feasibility. The HFA can be completed in just 1 day and is organized by adapted health system building blocks. The HFA tool and supporting materials are available online and can be adapted by other countries to assess readiness and track progress towards global newborn targets.
Thank you for watching. And if you feel you've had a tsunami of information, we just want to credit 150 authors, these 9 individuals, such a breadth and depth, and what they have covered in 1 minute per paper. And what we hope is that each of these papers can be practical and useful. So we're now going to have a short section where I'll make some comments on how we move faster together. My name is Joy Lawn. I'm a professor at the London School of Hygiene and Tropical Medicine. Very honoured to be part of the NEST team. And I'm especially delighted to speak to you live from Dar es Salaam. And as Alice mentioned, this week is the second RMN-CAH Science in Action conference in Dar es Salaam. Today, even the ex-president Kikwete was here talking about science and action. And that is exactly what this supplement is about. 10 papers are only 10 papers, but each of these papers came because hundreds of us were facing the same problem. And what we would love is, please use these papers, use the open access tools that come with them and make them better. Share your experiences so that we have two-way learning together. Join us so that we can go faster together. There'll be more papers coming. But the papers won't make a difference unless we have these critical ingredients of investment, implementation, actually acting on it, and then using the data to do better. And there are rich resources here, but more needed to be able to take that forward. And for all the lovely people online, I'm looking at the fantastic list of many friends and colleagues, including one of the people who won the essay prize yesterday for ideas on investment and implementation from Zambia. It's lovely to have you here. One of the mistakes we have made is that we accept for women and babies to do things as if it was a charity. Women have rights, and so do babies. And we can and must use this data to make a bigger case for investment. And I'm so inspired by the level of investment and commitment here in Tanzania. Just 2 weeks ago, the president herself signed a letter for scale up of neonatal care across rural facilities. The president's office is putting money into investment. And I believe that we have so much to learn for the level of ambition that was shown for many other health programs. And we can and must do that for babies too. And we can learn together. We have a really urgent way forward. How can we not just make the case for more money, but also implement and then measure the right things? And often less is more for measuring. So if we go to the next slide, I would like to pass to my wonderful colleague and a hero to many, Professor Bogali Wereko, and especially thank him for the exceptional work that he and 2 other editors undertook for this supplement. So I'm going to pass to him to make comments, and then we will still have time after that for questions. So please do post your questions and we will go to live questions after Bogali has made his comments. Over to you, my friend.
Thank you so much, Professor Joy Loan and all the NEST360 team. Good morning, good evening. I just want to start with a few things to recall that there was a big misconception for us here in Africa, where we were told that newborn health is very expensive and luxury. And that convinced many of us, and including the policymakers, and we didn't move anywhere. So we were quiet and silent for many years until almost 2005, when we knew that majority of the cause of newborn diseases could be prevented by very low cost, high impact interventions. Again, that led us to another misconception that many of our leaders, professionals, and also the policymakers were very reluctant to purchase equipment or devices for our NICUs. So we only depended on simple, things without including devices. As you all remember, the life-saving tools that WHO has listed even does not include any device except the KMC and some antibiotics. And probably if they mentioned it was very much little attention. So again, that has kept us moving very slow and off target to reach the MDG and later on the SDG target that is to come. But I will say thanks to the NEST360 team, now we started talking about the medical devices and the medical equipment that contribute a lot in reducing the neonatal mortality further. And to just mention some of the devices that is very much popular now and also accepted by many of healthcare professionals, reducing mortalities in small and sick babies is the CPAP machines and others. Now coming back to the BMC NEST360 Supplement series publication, very relevant studies have been done, and that was highlighted with the videos that just watched. So, just to quote, just two, the health facility assessment tools that developed to see the health facility readiness, the devices, the consumables, the guidelines, and the facility infrastructures. These were really eye-openers. And the training materials developed, the interprofessional training materials or education materials, are also extremely very important because it brings a new cadre of healthcare providers, the biomedicals. So I'll say finally that all these opportunities that we are given are instrumental in moving faster and reaching our goals, in SDG goals in all our countries. So I would like to thank one more time all the researchers, the coordinators, all team of NEST360. I hope that will be useful for all of us here in Africa. Thank you so much.
Bogali, thank you. Amasaganalu. I think you're known as the godfather of neonatal care in Ethiopia. So in closing, we'd like to credit BMC Pediatrics and thank them for their support and Springer Nature. And I think the next slide has the QR codes for going to the landing page. On the left-hand side, you can see where the papers are now live. So please use them. Papers alone are not able to save lives. It is science in action in our hands. And also the open access tools, which we'd really encourage you to adapt, use, share your experiences back. Now, we haven't got any open questions, but I want to flag really an incredibly important learning that Edith was in the middle of sharing. So Edith, when Professor Werker was just talking now, he was saying how important innovative education materials are as well as devices. Edith, could you maybe just share a learning with us from your experience, and particularly as a neonatal nurse, which is just so critical across Africa? Edith?
Thank you so much, Joy. Sorry, I was cut off earlier. But yes, innovative materials are really necessary for us to be able to work better, especially as nurses. The technology is available to make our work easier and to help us to assess our babies and to make decisions on what is needed. So the devices that are available now, use of CPAP, being able to start a baby on CPAP, that has really been useful. And the materials that have been developed by the team are quite simple, and whichever CPAP machine we have, we can apply the principles as have been described in the generic materials. So I'm praying and hoping that, and even as a nurse myself, I have used these materials to be able to not only take care of the baby, but also teach my colleagues on how to use CPAP. So you will find we have very simple videos. We have scenarios that give you real cases, which we can apply and discuss and then start our baby on CPAP. So I really feel that innovation, both in terms of the device and also the materials to be able to use, has really helped and made things easier. Thank you, Joy.
Thank you, Edith. And this is really in support of WHO guidelines and exciting work that's upcoming also to try and inform how many neonatal nurses we need so that we can increase the numbers. I would really encourage all of you who are here to post in the chat what's the change you would like to see by World Prematurity Day next year. We're really privileged now to have more attention, and yet there's a sense of urgency. And as Bogali eloquently said, we have an opportunity to go so much faster. What is the change that we would like to see a year from now? Yeah, humanitarian settings. This is a really important question, Samira. Maybe I could ask Bogali, is that something you would like to comment on with recent experience? What can we do in humanitarian settings to make sure those vulnerable newborns, it's in the news every day, heartbreaking from Gaza at the moment?
Yeah, actually we do have here in Ethiopia also internally displaced people due to internal conflicts or natural disasters. So we do have a lot of babies who are in the humanitarian setting. So I think there is a very clear guideline by UNICEF where we can have interventions for basic newborn care, at least care at delivery and beyond. If we have, if we have newborn babies in this setting, we can do interventions like minimum of essential newborn care 1 and 2 are possible, and also one can do basic assessment for sepsis and treat sepsis and breastfeeding if possible. If not, then one has to really discuss with all aid organizations to supply nutrition and so on. So I think there are a lot to be done there.
Thank you, Bogali. And I think with the new evidence around kangaroo mother care and zero separation, this is something that is applicable in all situations, from humanitarian and without power to the highest neonatal intensive care units in high-income countries. There's also very helpful resources, I think, for the humanitarian group that have worked on neonatal care, and we are intending to have more learning resources on the toolkit and welcome suggestions for that. Any other questions that people would like to pose? Otherwise, I would really request maybe that all the panelists can put their cameras on for a minute. And want to thank all of those involved. And many of you who are on this call are also really driving the learning. We want to see more science led from Africa, used in Africa, And we want to go faster together. Across Africa, we need to go at least twice as fast for newborns in the next 7 years. Thank you all so much. And when we dress in purple on Friday, let us also make sure that we ask. Let's ask for more money. Let's ask for more nurses. Let's ask for more space. Let's ask for more equipment, and let's make things move faster together.